Okay, so you may have heard about the possible erectile dysfunction that is taking place with people who have contracted COVID-19. So, or I should say, have contracted SARS-CoV-2. So what I want to do is go over this paper, which is still in its preprint stage. It's an early access of this particular paper, and here it talks about some of the different sex hormone changes that are experienced when people have contracted COVID-19, and then they also want to postulate the link between higher estrogen levels and actually being able to fight off the virus much more quickly. And so this is also going to lead up into another paper that I have found, which is how SARS-CoV-2 might be able to increase the amount of aromatase in the lungs. So just so we know, CYP19A1, this is an aromatase, which is something that will turn androgens or things such as testosterone into estrogens such as estradiol. And so this is verifying some of the claims that we are seeing in this particular paper. So in this paper, we're seeing that although testosterone doesn't seem to be significantly altered, the free testosterone, the testosterone that is not bound by proteins, it seems that it might be a little bit higher in people who have contracted COVID-19. The bioavailable testosterone might be a little bit higher if you have contracted COVID-19. However, and this is an important thing, the follicle stimulating hormone is significantly decreased, the luteinizing hormone is significantly decreased, and prolactin may or may not be a little bit higher. There were other papers that I read that were preprints that said that there was a significant prolactin increase in severe COVID-19. Here, we're dealing with more moderate and mild cases, so I should say more moderate. I don't think they have any mild cases, and it only seems to be a little bit higher, although it is above the typical threshold that we would see for prolactin levels. And then also estradiol, or one of the estrogens, seems to be significantly increased, very much so in people who have contracted COVID-19. And then another thing to look at is between people who had long COVID, people who have been shedding viruses for more than 50 days versus people who stopped shedding in less than 50 days of the virus and they were no longer testing positive, it appears as though that estradiol or this estrogen is significantly lower in people with long COVID than uh, people who have had a short run of COVID-19. So here we have the normal group, people who have COVID-19 and are viral shedding for a normal period of time. Here we have the long-term group where they were shedding for more than 50 days. And if you were shedding for more than 50 days, you seem to have lower estradiol levels, lower estrogen levels than those who recovered in the normal time frame. Okay, so with that, you can stop the video now if you want to, but I'm going to go into a little bit more detail of what the significance of all this stuff is. So, with a little background, this is the paper, I should say. So, effects of SARS-CoV-2 infection on male sex-related hormones in recovering patients. So, here's the background: a novel coronavirus, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, which is causing the pandemic of COVID-19, may attack the testes by angiotensin converting enzyme 2. So the Chinese have actually been a little bit more on top of this than Western countries have. I think Italy has brought this up to a lot of people's attention that it is dangerous, or we should focus on androgens because the ACE2 receptor, is highly expressed in the testes, right? So since they're highly expressed in the testes, this could be one of the reasons why men seem to be a little bit more vulnerable to COVID-19 than, say, women are. But let's continue. So to assess whether SARS-CoV-2 infection can affect sex-related hormones and testicular function in recovering patients. So this is the objective. And here we have the materials. The patients were separately classified according to the duration of viral shedding. So the long term versus normal term, and the disease severity, so moderate versus severe group. Differences in sex-related hormone levels were compared between groups, and later regression analyses were used to compare the association of testosterone and estradiol with various clinical and laboratory factors. And this is an oversimplification. They looked at a lot of different, or I should say, they looked at more sex hormones than what they're saying here in the materials and methods. So the results, and this is one of the problems that I had with this particular paper, that there were only 39 COVID-19 infected patients, which we shouldn't be this far behind, but unfortunately, I shouldn't say unfortunately. In China, apparently, um, COVID-19 is pretty much a thing of the past thanks to their aggressive policies in fighting it and also their phenomenal testing and tracing system that they employed in order to prevent unwanted community spread of COVID-19. So as a result, papers that are coming out of China are going to have very small sample sizes because they don't they simply don't have the people contracting COVID-19 now like they were at the very beginning of the pandemic. So this is just, I mean, the United States really should be picking up the mantle and doing more of these biochemical analyses so that the American public knows what the hell they are ascribing to if they do end up contracting this. So, anyways, long story short, 39 COVID-19 infection patients were included in this study. The mean testosterone level was in the normal reference range, while the mean estradiol levels uh, was above the normal limit. So here, out of the 39 COVID-19 patients, the level of testosterone that they had was pretty similar to a control group that they used, almost exactly the same, really. And then but the estradiol levels were significantly increased in the COVID-19 patients. Anyways, there was no significant differences between the long-term positive and the normal term groups in testosterone. So testosterone didn't seem to play a role in whether or not you had long COVID or short COVID. And also the follicle stimulating hormone, the luteinizing hormone, prolactin, and the testosterone to luteinizing hormone ratio, those were all insignificant differences between those two groups. However, estradiol was higher in the normal term group than the long-term positive group. Moreover, there were also no significant differences between the moderate and severe groups in sex-related hormones, duration of viral shedding, or the serum biochemical or inflammation indicators. So this is saying whether or not if you had moderate COVID or if you had severe COVID, apparently there wasn't much of a difference in how long you were shedding virus. So that to me is significant because I would presume that if you had a more serious case, you probably would be shedding longer. Or I guess you could make the counter argument that maybe the virus has just found a host that is more suitable for hosting it for a longer period of time. And so it's not going to elicit as strong of an immune response in that person. And if it doesn't elicit as strong of an immune response, then the virus is probably like living happily within the body so that it can infect more people. Because these viruses, they're not trying to kill you. They're just wanting to survive and duplicate. And so, if you have a mild case or a moderate case, that could be something that could effectively make the virus more likely to spread, right? Because if it's severe, then you're stuck at home or you are unable to interact with other people, and your immune system, knowing that you're very sick, is probably going to get kicked into overdrive to try to combat this virus. Anyways, moreover, there was also no significant differences between the moderate and severe groups in sex-related hormones, the duration of viral shedding, or serum, biochemical, or inflammation indicators. Additionally, regression analyses showed that there were no associations between the testosterone level and the clinical and laboratory factors, while estradiol was negatively associated with the duration of viral shedding. So in conclusion, in males infected with SARS-CoV-2, most sex-related hormones remain within the normal reference ranges after recovery from COVID-19, and no significant associations were observed between the testosterone levels and disease duration or severity. At present, there is insufficient evidence to show that SARS-CoV-2 causes hypogonadism and sterility, but the potential risk should not be ignored. So, what do I want to say about this? So I think I will skip down to the actual results. And this is, yeah, I'll skip down to these results and then we'll go down to the conclusion so that we can hear more about what the authors think about this particular data. So the age between the patients with COVID-19 and the patients without COVID-19, the average age was a little bit lower in the COVID-19 patients. The body mass index was a little bit lower in the COVID-19 patients. So this might be, those are two things that might actually skew the sex-related hormone levels to make it seem more positive for the patients with COVID-19. And the reason is, if you are younger and if you have a lower body mass index, those both could theoretically make it, what would the word be? Improve your sex hormone profile. And you would theoretically be a little bit healthier. Your body would be a little bit more virile. So your sex hormones might be more within the normal range if you are both younger and have a lower body mass index. But yeah, so unfortunately, they didn't have the normal range for whatever cohort this is. And another thing that I dislike about this paper is that we're missing a lot of data. Well, here it's not available because these people don't have COVID-19, but we're missing a lot of data on like comorbidities, for instance, because those can really significantly affect how the sex hormones are going to be, the distributions of the sex hormones. So unfortunately, we do not have that information right here. But anyways, let's go through. So with the COVID-19 patients, we had 0 who were in the mild group. However, we had 20 in the moderate, 17 in the severe, and 2 in the critical. I wish we had more, and in fact, I really wish that we had a good amount of mild cases, because I really want to know what is happening in these in the people who are very little or symptomatic, or people who show no symptoms. Are their hormones also being affected in some way? And the fact that we're doing everything from moderate to critical means, like, indicates to me that it probably is. Um, if you are ever sick of anything, your sex hormones are going to be affected, right? So, I mean, what I want to know is what makes coronavirus different from other diseases that you can contract, or the flu even. Anyways, so the duration of viral shedding, so 19 were in the normal term, 20 were in the long term. Here are the symptoms, here are the comorbidities, and like I said, they don't have comorbidities listed for the people who did not contract COVID-19. Here are the serum biochemical indicators, and it looks like there's not much difference in either of them. Maybe the creatinine is a little bit higher, but not significant. And here we have the inflammation indicators. It looks like white blood cell count, pretty much the same. Lymphocyte count, pretty much the same. The C-reactive protein, this is this is a protein that if you find it in the blood, probably means that certain, I believe, muscle and or heart tissues are rupturing or inflamed, which is allowing this C-reactive protein to leak into the bloodstream. And so this is a good biochemical indicator of inflammation. And then here we have interleukin-2 receptor and interleukin-6 and tumor necrosis factor. And unfortunately, they didn't have the levels for the control group. However, they did leave the standard reference ranges for all of them. And it looks like the standard reference ranges are, well, for these, they're within the same, but the tumor necrosis factor was above the threshold in this particular group. So, yeah, we have some inflammation probably, and we knew that already. This is, though, if I remember correctly, this is after recovery. So after they've recovered, I should go into more detail. But yeah, if they have these pro-inflammatory markers after they've recovered, that's not a good sign, especially for the C-reactive protein. So it looks like this is in the normal range. Tumor necrosis factor, little high, but it's approaching the normal range. Yeah, my main concern would be the C-reactive protein being that elevated when the normal range is, well, when the normal people have 1.31, So the sex-related hormones, this is why we're here, right? So the testosterone seemed to be pretty much the same. The free testosterone, so just testosterone, most of it is bound to different proteins in your body because, well, for one, steroids they're very lipophilic, they're very fatty, they do not do well just existing in the solution, which is why the concentrations are very small. So here the concentrations are nanograms per milliliter, right? So very small amounts of these things can elicit very strong effects. But so most of it is going to be bound to different proteins. And so we have the sex hormone binding globulin, and we also have albumin, which are really important in binding the steroids and the estrogens in your body. So let us sex hormone binding globulin, yeah. And let's look up the Wikipedia. So this is sex hormone binding globulin, and it's one of the main proteins that is actually binding to testosterone. And here we can see, I believe, is this one of the, I wish that they labeled it. I presume that this is where the actual steroid and or estrogen will fit itself into in the protein. But anyways, this is a protein that is binding to the majority of the sex hormones in your body. And so when they're talking about, or when we are talking about free testosterone, we're talking about things that are not bound to proteins. And so it appears as though free testosterone may be significantly higher in people who contract COVID-19 versus those who don't contract COVID-19. And furthermore, the bioavailable testosterone seems to be just moderately a little bit higher in people who contract COVID-19 versus those who have not contracted COVID-19. So, I mean, if you just read this, you would probably think that if you contract COVID-19, that your testosterone levels might actually be a little bit higher, or at least your bioavailable testosterone levels might be a little bit higher. However, this could be actually really bad if your other hormones are not in check. So here we have that the follicle stimulating hormone is significantly reduced in those who have contracted COVID-19 versus a normal reference range. So just, follicle stimulating hormone and luteinizing hormone, these hormones actually will go up and down throughout time. But the fact that if we took a snapshot of 39 patients, their average was significantly lower, this could be indicative of some problem. So just so that we are all aware, let's get up follicle stimulating hormone, testosterone. You know what, I'm going to have to look it up 1 second. And I like getting the Wikipedia article. So, and let's look up in males, effects in males. So, just so you know, this is what the follicle stimulating hormone looks like, and it plays an important role in having the gonads function properly. It's a gonadotropin, and just so you know, everything that ends in tropin, these are hormones that help improve or help things live and survive and grow. So a gonadotropin is something that helps the gonads or convinces the gonads that they need to continue doing what jobs that they're doing. So the gonadotropins, these are glycoprotein hormones secreted by the gonadotrope cells of the anterior pituitary of vertebrates. And so these are the types of gonadotropins: follicle stimulating hormone, luteinizing hormone, and other types of gonadotropins, right? So going down to the effects in males, FSH, follicle stimulating hormone, stimulates primary spermatocytes, which the spermatocytes are the cells that will turn into the sperm. It convinces them to undergo the first division of meiosis to form the secondary spermatocytes. So this is important in producing sperm. And follicle stimulating hormone will also enhances the production of androgen binding protein by the Sertoli cells of the testes. Okay, so these Sertoli cells, these are just they're the nursing cells. These are these long columns of cells that are in the seminiferous tubules that basically are holding on to the sperm cells or the developing sperm cells, and they are nursing these sperm cells so that they can turn into the final sperm. So here you can see these primary spermatocytes end up turning into these more developed sperm cells when they reach the very end of the Sertoli cell. And so an important part of this is that follicle stimulating hormone will go into these Sertoli cells, and these Sertoli cells will then produce this androgen binding protein. So remember when I said these steroids like being bound to some form of protein? Well, this is an example of a protein that can bind to it. So this is distinct from the sex hormone binding globulin. This androgen binding globulin is specific for the Sertoli cells, and it will actually help concentrate testosterone in the lumen of the seminiferous tubules. So let's go to androgen binding protein. What exactly it does? It's a glycoprotein produced by the Sertoli cells in the seminiferous tubules of the testes that bind specifically to testosterone, dihydrotestosterone, and 17-beta estradiol, which is a different type of estradiol than the estradiol that we have been talking about. Yeah, so E2 or O-estradiol. yeah, so let's continue down. So because androgen binding protein binds to testosterone and DHT, these hormones are made less lipophilic. So remember, these steroids, they're very fatty. They don't like to dissolve in water. So what this androgen binding protein does is it'll bind to the testosterone so that it ends up becoming more water soluble, and then it concentrates in the luminal fluid of the seminiferous tubules, or it concentrates in the areas that that the sperm are developing in, right? And so the higher level of these hormones enable spermatogenesis in the seminiferous tubules and sperm maturation in the epididymitis. So if you are not producing enough of this androgen binding protein, that is going to have significant consequences on your ability to produce sperm properly. So, ABP has the same amino acid sequence as the sex hormone binding globulin. The difference is the site of production and the addition of different sugar moieties. So, okay, I learned this. So the androgen binding protein is the same thing as the sex hormone binding globulin that I was talking about earlier. However, this one is produced specifically in the testes, and it actually receives a few different modifications on it after the fact that makes it more specific to the testicles. So, but as I was saying, if you're not producing any of that, that's going to be a problem. So, or if you're producing less of it, that's going to be a problem with your sperm production. So, continuing, so luteinizing, and that these people have less than the standard, right? The luteinizing hormone will also be a problem. So here it has it that it is significantly less in the COVID-19 patients, the recovered COVID-19 patients versus the standard group. So let's look at what luteinizing hormone does specifically. So also, this is a hormone produced by the gonadotropic cells in the anterior pituitary gland, and the production of luteinizing hormone is regulated by GRH, and from the hypothalamus. In females, it can do this, but one of the main things that we need to be considerate of is it stimulates Leydig cell production of testosterone. So if you are not producing enough of luteinizing hormone, your testosterone production might also be affected, or it might be affected in certain areas. So as we were saying earlier, a lot of people who contracted COVID-19 pretty much have the same testosterone levels as those who have not contracted COVID-19, right? But if you have low levels of luteinizing hormone and follicle stimulating hormone, there could be a synergistic effect that is causing an anti-male, or might be able to affect reproductive health of males specifically. So let's see if there's anything here that I want to talk about explicitly. I think no. Here, I guess we can look into the male secondary sex characteristics: penis and scrotum growth, facial hair growth, larynx elongation, lowering voice, shoulders broaden. Yeah, just typical secondary sex characteristics. So, I'm just looking to see if there's anything specifically that I want to talk about. And it looks like, no, I don't want to talk about any of this stuff. So, just so you know, we have all that taking place. And then also, it looks as though the prolactin is a little bit elevated. Not significantly, it looks like, but it is above the normal reference range that we use for prolactin. If you have been watching my videos, which more likely than not you haven't been, I did have a video on prolactin and why I believe prolactin is probably going to be elevated in people who contract COVID-19, specifically because there is a sequence in the genetic code, or in this, I should say, in the amino acid sequence of the spike protein, that if you were unfortunate enough to make an antibody against that particular protein or that amino acid sequence, you might have elevated levels of prolactin. So just so you know, that is something that I'm still concerned of. It looks like people may have a little bit of an increase in this paper. There was another preprint that I read that had it very significant, had the prolactin difference extremely pronounced. But yeah, and then there's also the estradiol levels, which are significantly increased in this particular in the COVID-19 cohort. So um, this here, we have the long-term positive group and the normal term group, and this is of the 39 that had contracted COVID-19. And it looks like the p-values are pretty standard, and nothing out of all these things, there doesn't seem to be anything significantly different except for the estradiol levels, where people who had normal term COVID, or I should say people who have had long-term COVID or long-term viral shedding, these people had lower estrogen levels or lower estradiol levels than those who were able to clear the virus quickly. So if you contracted COVID-19 and your estrogen levels went up significantly as a result, then it appears as though they were able to fight off the COVID-19 much more quickly than we would otherwise expect. So yeah, that could be a good thing. And then going to the clinical characteristics, it looks as though there isn't anything that is really significantly different between the two groups. So the only thing is the duration of the viral shedding, and which is how they defined the groups in the first place. And after they've done that split, it looks like there's not really anything that they can hang their hat on. Interleukin-2 receptor was close, but it's still within it still could be chance, right? So we don't want to do too much or assume too much. So with that, I think I'm going to call it, oh yeah, the discussion. So do I even want to go over the discussion? Because I think I've been talking enough. So here are the limitations. I do agree with some of this. First, the data may be biased to some extent due to the small sample size. So yeah, there's only 39 patients in this group. And that's just one of the unfortunate things that we experience when the groups that have started doing the research end up not having samples because they were effective at fighting off the COVID-19 with non-pharmaceutical interventions. So some researchers believe that there is a possibility of long-term endocrine metabolic complications in COVID-19. Therefore, the conclusions drawn in this study still need to be confirmed by a large sample size and follow-up monitoring of endocrine metabolic function. So yeah, definitely not enough. Definitely not a large enough sample size. Definitely not representative of the type of the COVID that we can experience throughout or in real life, right? Because they had no mild cases reported in this group. They really should also they should include blood samples of people who have died of COVID-19 as well. But I think that if the idea is to get people who have recovered, you can't really use dead blood samples. But regardless, or I should say blood samples of the deceased. Regardless, let's continue. So second, the age of the patients was older than that of the reproductive aged men, which may have led to less generalizable results. So yeah, that is something that I'm more actually interested in. What's happening if you're old? It doesn't matter as much. I mean, it still kind of matters, but it doesn't matter as much what your sex hormone levels are because you've already passed your childbearing ages, right? So, or child siring ages, and you don't care as much, and you're probably, yeah, sorry, I shouldn't make assumptions. So, regardless, I want to see what happens to young, healthy virile men when they contract COVID-19. I want to see their hormone changes. I don't want to see the hormone changes of people who are 70, 80. That doesn't matter to me as much. That's not going to have as much of an impact on society as if we have 10% of men who are now infertile and they don't even know that they're infertile until years down the line. That is going to have a significant effect on society. Whereas if we have infertilized 60-year-olds, that doesn't matter. That's not going to have the same sort of consequences on society. So with that, third, the glucocorticoids, such as methylprednisolone, were used in critical cases, which may affect the pituitary adrenal cortex axis, or the P, wait, yeah, and resulting in changes in sex hormone levels. However, methylprednisolone mainly inhibits the hypothalamic pituitary adrenal axis, not the hypothalamic pituitary testicular axis, which male testosterone mainly comes from. So, besides, the indications of methylprednisolone are strict and the application time was short, hence the negative feedback inhibition may have little effect on testosterone levels. So this is just another one of the problems that we have to deal with is when people are undergoing a disease, they're often prescribed medications, and it's very difficult to remove the effects of the medications from the actual disease, right? Which is why I wish that there were more mild cases, because we're not prescribing methylprednisolone, we're not prescribing um, the steroid treatments for people who have mild cases. And in fact, it could be detrimental for people who are in the mild group, right? So yeah, I really wish that we had this information, and unfortunately, we don't, because well, we've been screwing up left and right. So fourth, the estrogen level was detected by radioimmunoassays, but not through the liquid chromatography, um, mass spectroscopy, mass mass spectroscopy, mass spectroscopy. Just so you know that that's just another type of quantitative method that we use, and a new substitute with higher precision and sensitivity. However, the bias caused by detection method could be reduced by comparing with non-COVID-19 homogeneous patients. So even though they used an outdated method, um, and granted, sometimes the outdated methods are better, right? They're more reproducible. Regardless, they are arguing that it would have been better to use the liquid chromatography, but they didn't. Even so, we will select this to detect estrogen levels in our further study. So hopefully these people come up with another paper soon so that we can learn a little bit more about what's happening. So fifth, sex-related hormones are one of the factors that maintain males' sexual function and fertility, but hormone levels alone are not sufficient to determine whether an infection has damaged the testicular tissue. Therefore, large studies involving assessing more intuitive indicators, such as observations of testicular volume changes and pathological changes, erectile function test results, and semen quality results over longer follow-up period are required. And so, um, basically, I did have one of my audience members write to me saying that, well, I've had a few of them say that they've contracted COVID-19 while they are young, and then they still, I shouldn't say while they're young, but who are young, and they are experiencing they are experiencing erectile dysfunction. And this was happening before I had more people searching it up and, going to my video. And this is something that really needs to be addressed. Has it been fixed? How long did it take for their normal erectile function to return to them? Has it returned to them? I even had one person write that they've had consistency changes in their semen. Right? It's I think I remember them saying that their semen no longer was basically clear and was very, very liquidy, right? And so if they masturbated, basically they weren't producing a semen that had sperm in it. Now that would normally indicate um, that they would be infertile at that period of time, shooting blanks. And granted, I think that that is also indicative of high estrogen levels, so or low testosterone or low bioavailable testosterone in the testes at least. I'm not talking about the bioavailable testosterone of the body. I'm talking about in the testes. If you're not producing semen or if you are producing very clear ejaculate, it's probably an indicator of I should also say I'm not a doctor, so don't take any of this as medical advice, please. But it's probably indicative of being infertile at that period of time. So if I remember correctly, I believe that some people who go on hormone replacement therapy in order to um, do gender reassignment, they actually have a different the semen consistency is something that I remember reading about, or the consistency changes is something that I've read about in the past. So yeah, hopefully there is no long-term consequences in a large number of people. Hopefully, whatever long-term consequences are minimal and only affect old people, but we can't make that assumption right yet. So anyways, or additionally, we need to remember that male sexual function is a variety of factors, and you know what? I think we're done. Okay, in males, most sex-related hormones remained within the normal reference ranges after recovery from COVID-19, and no significant associations were observed between the testosterone level and the duration of viral shedding or severity of COVID-19. At present, there is no direct evidence to confirm that SARS-CoV-2 causes testicular injury leading to hypogonadism and sterility, but the potential risk should not be ignored. And then I should also say that there might be a survivor's bias in here as well, where people who have died, it seems as though they did have significant testicular damage as a result. So what I want to, I guess, think about is, one second, let me do this. What I want us to think about is this testicular damage only happening in people who die, or is there a subclinical amount of testicular damage that is happening in everyone else? It's just that it's very difficult to detect because it's subclinical, right? You're not going to a hospital for it. You're just, walking through it or walking it off, right? But if the damage is being done, it would probably be better to have it looked at, right? So with that, I think I am going to head on off. The next video that I'm going to do is going to be over this particular paper that has infected hamsters. This group has infected hamsters with SARS-CoV-2 to see what changes happen, and it appears to be there seems to be an upregulation of cytochrome P19A1, which is the aromatase, which will turn androgens into estrogens. And granted, I wonder how it's probably not reversible because it uses oxygen in the process. So yeah, but just so that we're all aware, if you have more of this cytochrome P19A1 expression or the aromatase expression, that could theoretically raise estrogen levels in the body as well, which is what we've seen in people who have COVID-19 or who have contracted SARS-CoV-2. Now, granted, what is causing it? Is it a protective role, right? Is your body producing this estrogen in order to stimulate your immune system, right? Because estrogen is really good for the immune system. In fact, I mean, women are much more able to fight off infection than men are because women have a much more robust immune system than men do. And I can definitely see how contracting COVID-19 might, for a healthy individual, a healthy male, it might be that the healthy male starts producing more estrogen, knowing that that increase of estrogen is going to help them fight off a viral infection. So with that, I think I'm going to head on off. 40 minutes. Thanks for watching if you stayed the entire time. And I hopefully will see you later today.